Hello everybody, we're going to switch a little bit to some medical topics, and with a quick presentation about Ilio-Tibial band syndrome, ITB syndrome. Just to let you know about the definition of this pathology, which is very common pathology. It's a friction or rubbing of the distal portion of the ITB on the lateral femoral epicondyle. And it's typically an overuse pathology. It's due to a repetition of flexion and extension of the knee. It was primarily described by Rene in '75. Just to remind you some important point about anatomy and what we are talking about. Yes, yes. Okay, we are discussing about this structure here, which you see is very closely linked to two muscles, the TFL, the tensor fasciolatae, and the gluteus maximus. Most of the time we think only about the TFL, but there are also some strong relationship with this very big and powerful muscle. It's of importance for the next slides and the next of the presentation. Also, it's important to remember about the distal attachment of this anatomical structure, which has a posterior portion, which is the one involved in the symptoms most of the time. Here you have a more detailed view of this portion, and you see this is a strange stuff. On anatomical book you see it is described as adipose tissue. So for some patients it's bursa, and it's a matter of controversy. We will discuss about it later on. Also remember that it's when there is a 30-degree flexion of the knee that you have the most important strain on this structure, and you'll see that it's when the knee is on 30-degree flexion that the problem, the possible ITB syndrome occurs. So this is, as I told you, an impingement syndrome between the posterior fibers that I showed you and the lateral epicondyle. It's mainly occurring during eccentric contraction of the TFL and the gluteus maximus, mainly to decelerate the leg during the running phase. And of course, this is an inflammatory disease, so you find some very obvious sign clinically and histological sign of inflammation on the posterior fibers. On a possible lateral synovial recess, this is an important thing because it's not approved by everyone, but not all surgeons. But some of the surgeons, they believe that in fact it's not a bursitis, it's something related to the lateral recess, and it's still under debate. And you have also part of inflammation on the superficial layer of the bone, the periosteum, and you might have a bursitis. This matter of bursitis, we always discuss about it as a clinical features when you have this kind of syndrome, but it's not so clear. So of course, if you look at the papers about the surgical treatment of this syndrome, you will find some papers mostly written by surgeons, of course, and they will probably show you this kind of stuff. But of course, and I'm going to be a little bit bad with my colleague surgeon. If you ask a surgeon to operate and to take off something, they will always find something to take off. I mean, it's like if you go for fishing on Saturday morning, you leave your home very early at 7. You let your wife and your kids, and then you come back home at 12 and you have no fish in your basket. What will you do? You stop in the shop, you buy a fish, and you come back home. Most of them, that's... So they can show you some kind of stuff like this, but we really don't know what is it. Is it a fibrotic tissue? Is it a bursa? Is it some adipose tissue? We still don't know. And basically there is no, if you look at the literature, there is no real agreement about the anatomical description of this structure that is removed during surgery. Some words about epidemiology of these syndromes, and you see that it's quite frequent. It's much more found in running events and distance running, long distance running. It's the most common injury in runners, affecting the lateral portion of the knee. You can see it also in cyclists, military recruits, and it's very rare in sedentary subject. It's very uncommon. That's very interesting. And also something very, very interesting. It's very rare, and I guess that your personal experience is the same than mine. It's very rare pathology in people taking part to multi-directional sports, like soccer, for instance, or fast speed sports. Like, you don't have this kind of pathology in sprinter. And we should keep this in mind, because this is very interesting from the pathophysiological point of view. The reason for that is probably that when you have a type of exercise like cycling or long distance running, the angular speed is reduced, so the time for friction is increased. So you have much more time to develop the conflict, the impingement. And also, it's very obvious when you have beginner cyclists that they pedal with low pedaling rate, so that they are more prone to this kind of pathology. And if you increase the pedaling rate, the angular velocity is higher, and you have this less occurrence of this pathology. So about diagnosis, well, I think diagnosis is not a big issue. If you are a good clinician, it shouldn't be a big problem to set the diagnosis of the ITBS syndrome. Anamnestic time is, of course, very important. You have to look for a sharp or burning pain. Usually it gets worse when you go for downhill running, or if you have to lengthen your stride. It's typical what the patient tells you. And also something which is very important for me is the progressive onset of the pain. Typically the patient tells you, I went out for my running activity, I start to have a small pain, and then it increased, and I had to stop. I took the mobile phone, I called my wife, she took me back home. That's typically when you have, and if the pain is on the lateral epicondyle, it's 99% sure this is a problem with Ilio-Tibial syndrome. It's very simple. From the clinical examination, you have to look for tenderness, possibly a swelling because of this so-called bursitis. You have to look for the pathognomonic test, which is the noble compression test, which is described here. It's very easy to do, and you have to look while pressing the ITV at 30 degrees of flexion. You have to reproduce the pain on the patient. There is also another test called the Ober or Ober modified test, which is shown here. I don't use it very frequently, but just for you to let you know, this is the starting position, and this is what we call a negative test, and this is a positive test. So you see that this is the classical Ober test. In the modified, you have almost the full extension of the leg. And when you have a positive, it means that you have this kind of, it attests for a kind of retraction of this structure here, and you can also reproduce the pain here. And when you let the leg, it doesn't go down, it stays like this. This is a little bit too obvious in my opinion, but this is just for you to understand how it works. But I believe that, and if you have to remember only one thing from my talk, is that the ITB syndrome is, you have to think about biomechanics. It's very important. So during your clinical examination, it's important that you look for all the possible biomechanic risk factors on your patient, on your athlete. You have to look first for an excessive internal rotation. This is very frequent in this kind of pathology. For anatomical or functional leg length discrepancy, what I call functional is that people running always on the same side of the road, or turning always on the same clockwise or anti-clockwise on the stadium. It can induce this kind of stuff. A genuine varroum is also to be seeked and looked for with an excessive foot supination. More uncommon, check the flexibility of the ankle, and usually you will find a decreased ankle dorsiflexion. This is a risk factor. Also, it has been described that it's not very easy to measure, but take a look at the width of the ITB at the lateral epicondyle. And also look for the flexibility of the iliopsoas and rectus femoris muscle with this kind of test, which is a Thomas test, which is also testing, by the way, the TFL flexibility. In my opinion, there are some differential diagnoses, but it's not so complicated to cope with this. Sciatalgia might be a problem. I think this is not a problem. If you do proper and careful examination, this shouldn't be a problem too. And this is typically neurological stuff, so you should have some neurological symptoms on the lateral side of the of the tide, so it's okay. One more time, also this is a very practical situation. Most of the time the patient arrives to the consultation, they don't have pain. They say, last week when I ran, I had this pain, but you perform the clinical examination, everything is normal. So if you have a good facility, it's better to send them running, and then you do a sensitivation of your clinical examination, and then you examine again. Or if you have, like I do, a treadmill not far from your office, they go for the treadmill running, and then you wait for the onset of the symptoms, and then you do clinical examination. No need, in my opinion, for paraclinical examination. Maybe ultrasound could be helpful, X-rays in some rare cases, MRI for differential diagnosis or associated diagnosis. Treatment. Well, acute form, when you have acute exacerbation of pain, of course, it's very simple: rest, ice, non-steroidal anti-inflammatory, physiotherapy. If no effect of this treatment at 3 days, and if it's very painful, you could consider a local injection of glucocorticosteroids in the bursitis. But to tell you the truth, if you look at the literature, there are no very well conducted study concerning conservative treatment and the effect of this conservative treatment on ITB syndrome. Surgical treatment could be also a possibility, but it's not so frequent. Some more time about conservative treatment. Of course, you should fight inflammation. You should look for technopathy, especially in cyclists. This is very important. What about orthotics? Well, I prescribe orthotics in this kind of pathology, but there is very few evidence. There are very few evidence about that. We are missing studies. Obviously, it works, but we don't know. Well, we should have some more studies on the field. And also, we ask for stretching the ITB. So, stretching the ITB is a phantasm, in my opinion, because when you do this, you don't stretch the ITB, because the ITB, the distal part of the ITB is 3 millimeters thickness. So believe me, to stretch this is not so easy. And it was published, this is very interesting, average length is 88 centimeter. If you stretch, you will gain 0.2%, so it's 1.8 millimeter. And it's not because you're going to change the length from 1.8 millimeter that you're going to change the complete course of the pathology. And of course, fortunately, it's not stretchable, because I just would like to remember, and I'm sad that it wasn't mentioned this morning in the surgical session, that there is also a way to reconstruct the crushate ligament with the Macintosh fasciolata. And we use this graft, and it's nice that it's not stretchable, otherwise the result would be a disaster. So most of the time when you do this, you just stretch the muscle. You don't stretch the fibrotic part. Take a look to the abductors. It's very important. This is a very interesting study, a recent one from Grow, which clearly show that you have in ITB patients a deficit in hip abduction. And you see they compared while running, they did this kind of motion analysis, and they compared two groups of patients, one suffering from ITB, the other one control, and you have a clear deficit in abduction. So you have to stretch the abductors. This is very important. But sometimes it does not work. Even if you had some PRP treatment, even if you do some shockwave therapy, it's still a failure. So we have to understand a little bit more why this is a failure. And that's what I wrote. You don't look only in the sagittal plane, because you could believe that it's only a pathology which is focusing on the sagittal plane. But you should on the frontal plane. You should also look on the sagittal plane. And this is a very nice study, which clearly show, one more time, if you compare the normal patient and the ITB patient, that you have some significant decrease in velocity for flexion of the hip, extension of the hip, adductor and abductor of the hip too. You see, the ITB patient, they have strange pattern, locomotory pattern, and strange decreased velocity for most of the movement of the hip. And it's also the same with the knee. They have decreased velocity for flexion and extension in the knee, and even for the rear foot. It's already so. It means that, you see, it's an overall problem of biomechanical failure, I would say, that leads to this specific problem to the knee. So, also you should look in your conservative treatment to increase the range of motion of both three main joints of the lower limb. Stretch adductors, gluteus, and also you have to fight against trigger myofascial restriction for all these structures. So what about maybe, I don't know, this is just an idea about the specific muscle speed training of this muscle and joints. This is very important. And sometimes surgical treatment is necessary. From my personal practice, it's not so often, but this is what can be offered to the patient. And now you have some patient, I don't know if it's you have experience about that, they propose some arthroscopic treatment with a resection of the lateral synovial recess with some good results. Basically, the results are good, but one more time, no evidence, no level 1 evidence study, and of course, no meta-analysis. So my conclusion will be very simple. The diagnosis, in my opinion, is quite easy, but you have to do a biomechanical physical examination. That's very important. Look for the range of motion of the 3 main joints and combat myofascial restriction. Look for technopathy, and this is biomechanics is very important. I guess those of you who live here, they know, and you can here see a hip, a knee, ankle. Thank you very much.